I'm about to tell you something that could save your life, and it has to do with that maddening pattern so many seniors shrug off as just my bladder. Waking up around 2 or 3 in the morning, every single night. You shuffle to the bathroom, you empty your bladder, you crawl back into bed, and then you lie there staring at the ceiling, wide awake. You tell yourself, if only my bladder would behave, I'd sleep fine. But for a huge number of adults over 60, that is not what's really happening. Your bladder is not the main problem, it's the messenger. The real problem is something deeper, changes in your brain, hormones, nervous system, and sometimes your heart and breathing that are quietly wrecking your sleep and raising your risk of high blood pressure, atrial fibrillation, heart attack, stroke, and dementia. I'm Dr. Claire Whitmore, and after 2 decades as a cardiologist, I've watched thousands of seniors come into my hospital with heart rhythm problems, strokes, and heart failure that were fueled, often for years, by bad sleep and undiagnosed nighttime conditions. When I take their history, I hear the same line over and over, "Doc, I'm up at 3 a.m. every night to pee. I thought it was just my age, or my prostate, or my bladder," and too often everyone focused on the bladder, while the real danger was left untreated. By the end of this video, you'll know exactly why waking at 3 a.m. is almost never just a small bladder issue, what hidden problems it can point to, including sleep apnea, heart failure, blood pressure and hormone issues, and a step-by-step plan to bring to your doctor so you can finally sleep longer stretches and protect your heart and brain at the same time. I'm not going to give you the fix yet, because if I do, some of you will write down no water after 7 p.m. and miss the much bigger, more serious issues. You need to understand what's happening inside your body first. Before we go on, comment below with your age and how many times you usually get up at night to pee. Something like 72 1-2 times, 81 3-4 times, 68 none, or 77 every night at 3 a.m. I read these. I need to see what seniors are actually living with. Let me tell you about Margaret. Margaret was 74 when I met her. Former nurse, widowed, lived alone in a small house. On paper, she wasn't in terrible shape. 5'4", 162 pounds, blood pressure around 138, over 82 on a single pill, cholesterol on a statin with LDL 96, HDL 54, a 1C 6.2%, prediabetes, no prior heart attacks or strokes. She took a blood pressure pill, a cholesterol pill, something for reflux, and a baby aspirin. Her chief complaint at first, "I'm tired all the time, doc. I feel like I never sleep." When I asked about her nights, she said, "Well, I fall asleep okay around 10:30, but like clockwork, I wake up at 3 a.m. to pee. Every night, sometimes twice. My urologist says my bladder is just getting small with age." She had seen that urologist because of this exact pattern. He had checked her urine, ruled out an infection, done a bladder ultrasound. Prostate issues weren't relevant. She was a woman. He told her, "You've got nocturia, nighttime urination, pretty common at your age. Try cutting back liquids after 7 p.m. We can add a bladder medication if it really bothers you." So Margaret stopped drinking after dinner. She limited her tea. She took the bladder pill. It may have changed the timing a bit, but it didn't change the core pattern. She still woke up almost every night between 2:30 and 3:30 with a strong urge to urinate. She would go, come back to bed, and then lie there wide awake, heart pounding slightly, mind racing. Often she was up until 4:30 or 5, drifting off just before dawn. By 8:30, her alarm would go off for a doctor's appointment or errands, and she'd drag herself out of bed feeling like she'd been hit by a truck. At 72, her blood pressure crept up, 146 over 88. Her doctor increased her medication. At 73, she developed new palpitations, a fluttering sensation in her chest, often in the middle of the night when she lay awake after her bathroom trip. Her primary care doctor said, "Probably just extra beats. We all get them." He ordered an EKG in the office at 10 a.m. It was normal. He told her not to worry. Over that year, her memory and mood worsened. She'd mix up plans, she'd snap at her daughter on the phone. "I'm just exhausted," she'd say, "and this stupid bladder won't let me sleep." What no one had really asked her in detail was what happened before and after those 3 a.m. awakenings. So I did. "Do you ever wake gasping or feel like you're choking?" I asked. She thought, "Sometimes I wake with my heart pounding like crazy, and I feel like I took a deep gasp. I always thought it was a bad dream." "Do you snore?" "My daughter says I sound like a chainsaw when she visits," she admitted, embarrassed. "And she says sometimes I'm quiet for a few seconds and then snort and gasp." "Do you wake with a dry mouth or morning headaches?" "Dry as a desert," she said. And yes, I get headaches some mornings. Do your legs ever swell during the day? By the evening, my ankles are like sausages, she said. But they're better by morning. That's just my age too, right? This was not just a small bladder. This screamed untreated sleep apnea, possibly with early heart failure and nighttime blood pressure surges. Her 3 a.m. bladder problem was likely a sign of something much bigger. But before she came to me, nobody had connected the dots. The crisis that brought her into the hospital came on a Wednesday in March. She had gone to bed at 10:30 as usual. At 2:58 a.m., opposite 58 a.m., she jolted awake with a desperate urge to pee and a crushing sensation in her chest. She swung her legs out of bed and stood up. The room tilted. Her heart was racing wildly, not just pounding more than she'd ever felt. She wobbled to the bathroom, sat down, and urinated a large amount. As she stood up, she felt a wave of nausea and tightness in her jaw. She made it to the bedroom, sat on the edge of the bed, and realized she could not catch her breath. Her chest pain was now a heavy pressure radiating to her left arm. She looked at the clock, 3:06 a.m. For a moment she considered waiting it out, but something in her nurse's training screamed at her. She grabbed her phone and dialed 911. When the paramedics arrived, they found her pale and clammy, breathing fast, clutching her chest, blood pressure 182/96, heart rate 132, irregular. The EKG in her living room showed atrial fibrillation with a rapid ventricular response and changes suggesting a possible heart attack. She was rushed to the hospital. In the ER, we ran labs. Troponin, the heart attack marker, was elevated. BNP, a marker of heart strain, was high. An urgent echocardiogram showed a slightly enlarged left atrium and a pumping function just a bit reduced from normal. She was in a fast, chaotic rhythm that can be triggered and worsened by chronic stress on the heart, including years of bad sleep and untreated sleep apnea. We stabilized her rhythm and rushed her to the cath lab. She had a significant blockage in one coronary artery that we opened with a stent. Over the next 24 hours, her rhythm fluctuated between normal and atrial fibrillation. Every time she drifted into deeper sleep, her oxygen levels dipped on the monitor and her heart rate jumped. We put her on a CPAP mask as a trial. Her oxygen stabilized. Her heart rhythm calmed. When I sat down with her and her daughter the next day, I asked again about her nights. Together we pieced it together. For years, she had snored heavily. Several times a night, her airway would collapse. Classic obstructive sleep apnea. Her oxygen would drop. Her brain would panic. Stress hormones would surge, spiking her blood pressure and heart rate. Those surges triggered her kidneys and heart to release atrial natriuretic peptide, a hormone that tells your body to dump salt and water. That's why she had to pee at 3 a.m. Her bladder was simply the first thing she noticed. The real sequence was apnea row, stress surge, hormone release, increased urine, wake up to pee. On top of that, when she lay down at night, fluid that had pooled in her legs all day shifted back into her bloodstream. Her heart, already under strain, had to handle a sudden extra volume, raising nighttime blood pressure and urine production. Early heart failure, untreated sleep apnea, and nighttime surges, all of that was pounding on her heart and brain for years, disguised as a bladder issue. The heart attack was the loud alarm. The 3 a.m. bathroom trips were the whispers she and her doctors had missed. So when you tell me I wake up at 3 a.m. to pee, my bladder is the problem, I do not shrug. I lean in. Because research shows that nocturia, waking to urinate at night, is independently associated with higher risks of cardiovascular events and death in seniors, even when you account for prostate or bladder issues. In other words, it's often a symptom of bigger underlying problems: sleep apnea, heart failure, poorly controlled blood pressure, diabetes, even kidney disease. I want you to pause and check in with yourself. Comment again, but this time use this format: age, wake time, how you feel. For example, 73, always 3 a.m., wide awake after, 80, 2-3 a.m., heart pounding, 69, multiple times, fall back asleep easily, or 77, once at 4 a.m., fine. If you snore loudly, add snore. If you ever wake gasping or choking, add gasp. If you have leg swelling by the end of the day, add swelling. So your comment might look like 75 to 3 a.m., wide awake, snore, gasp, swelling. This is not for diagnosis, but it helps you see patterns you may have been ignoring. Let's break down what's actually supposed to happen at night in a healthy body and what goes wrong. In younger adults, and in many healthy older adults, the body has a beautiful nighttime system. As evening comes, your brain increases melatonin, your core temperature drops, and your kidneys get a strong signal from a hormone called antidiuretic hormone, ADH, to slow urine production. That's why most people can sleep 6-8 hours without needing to pee. Your bladder fills slowly, and your brain dips into deeper sleep cycles. After 60, several changes make this system more fragile. First, your ADH rhythm weakens. Many seniors don't get as strong a nighttime signal to concentrate urine. The kidneys keep making more dilute urine overnight, so your bladder fills faster. That's one reason night trips increase with age. Second, sleep becomes lighter and more fragmented. You spend less time in deep slow-wave sleep, more time in lighter stages where you're easily awakened by pain, noise, or the slightest sense of a full bladder. Younger, you might have slept through the same bladder volume that now wakes you up. Third, common conditions in seniors hijack this system. Obstructive sleep apnea, OSA. When your airway collapses repeatedly at night, your oxygen drops. The negative pressure in your chest and the strain on your heart cause release of atrial natriuretic peptide. That hormone does two big things: tells your kidneys to dump salt and water, and suppresses ADH. Result: more urine at night. Studies have shown that treating sleep apnea with CPAP often reduces or eliminates nocturia, even with no change in bladder or prostate medications. Heart failure or fluid overload. When your legs swell during the day, that's extra fluid sitting in your tissues. When you lie down, that fluid returns to the bloodstream, increases the volume your heart has to pump, and your body tries to get rid of it by increasing urine. That's why many heart failure patients urinate multiple times at night. Poorly controlled diabetes or high blood sugar. Elevated glucose pulls water with it into the urine. If your blood sugar is high in the evening or overnight, your kidneys will make more urine. Again, more trips, but the cause is not your bladder. Uncontrolled blood pressure. High nighttime blood pressure stresses the kidneys and heart. It's associated with nocturia and with strokes that often happen in the early morning hours. So yes, for some seniors, the bladder or prostate is part of the story. Overactive bladder, prostate enlargement, infections, all real. But for many of you, especially those waking at the same time every night with snoring, gasping, leg swelling, or pounding heart, the bladder is the victim and the messenger, not the main culprit. The research backs this up. Studies in journals like Sleep and Urology have shown, in patients with obstructive sleep apnea, nocturia is extremely common, up to 70–80% in some series, and often improves significantly with CPAP treatment. In large population studies, seniors with nocturia, waking 2 or more times per night to urinate, have a higher risk of overall mortality, cardiovascular events, and falls. The association remains even when you adjust for prostate size and fluid intake. This tells us nocturia is a marker for systemic disease, not just a local bladder problem. In heart failure patients, the number of nighttime urinations correlates with the severity of their condition and improves when heart failure is optimized. So what do you do with this information? Let's talk about your action plan. First, you need data. For at least 7 nights, keep a simple sleep and bathroom diary. Before bed, write down what time you went to bed, what you drank in the 3 hours before bed. Type an approximate amount, what medications you took in the evening and their timing. During the night, jot or have a partner jot down what times you woke up, whether you got up to urinate, roughly how much urine, small, medium, large, how you felt, heart pounding, gasping, headache, fully awake, versus drowsy. In the morning, write what time you finally got up, how rested you feel on a scale of 1 to 10. Whether you had a dry mouth or morning headache, this 1-week snapshot can be incredibly revealing. Patterns emerge, always waking between 2 and 4. Huge first nocturnal urination, despite stopping liquids early. Heart pounding? These details give your doctor clues. Second, screen yourself for sleep apnea. You are not diagnosing yourself, but you can ask, do you snore loudly enough that someone in another room might hear you? Has anyone seen you stop breathing, choke, or gasp during sleep? Do you wake with a dry mouth or morning headaches? Do you feel unrefreshed, foggy, or very sleepy during the day, even after what seems like a full night in bed? Is your neck circumference larger, shirt collar size 16 or more in men, 15 or more in women? Are you overweight or have high blood pressure, atrial fibrillation, or heart failure? If several of these are true, your 3 a.m. awakenings plus nocturia may be the tip of the sleep apnea iceberg. Third, check for signs of heart failure or fluid overload. Do your ankles or lower legs swell by evening, leaving sock marks? Do you get short of breath walking up a single flight of stairs or lying flat in bed? Have you gained several pounds over a short period without trying? If so, Nighttime urination can be a sign your body is trying to dump that extra fluid. Fourth, yes, you should look at basic bladder hygiene. Are you drinking large amounts right before bed? Are you taking diuretics, water pills in the evening instead of the morning? Are you drinking caffeine or alcohol at night, both of which increase urine and fragment sleep? Have you had your urine checked for infection or blood? But here's the key, do not stop at, I'll drink less water. That is the superficial fix. If you simply dehydrate yourself and leave untreated sleep apnea or heart failure, you may feel slightly less full in the bladder, but much worse off in your heart and brain. So here is a simple, structured plan to take to your doctor. Step 1. Bring your sleep bathroom diary and describe your typical night in detail, including snoring, gasping, palpitations, leg swelling, and what time you wake. Step 2. Say these exact words. I know my bladder may be part of this, but I'm worried there's more going on, like sleep apnea, heart failure, blood pressure issues, or diabetes. Can we evaluate those? Step 3. Ask about appropriate tests. These might include Myers Leap study, home or in a lab, to look for obstructive sleep apnea, blood work for kidney function, blood sugar, A1C, and sometimes a BNP level to assess heart strain, an echocardiogram if there are signs of heart failure, ambulatory blood pressure monitoring to see if your pressure is spiking at night, an ankle brachial index or leg exam if you have circulation problems and leg swelling. Step 4. Review your medication timing. Diuretics are often best taken in the morning. Some blood pressure pills can lower nighttime pressure more than needed. Others can help smooth dangerous nighttime spikes. Never retime or stop a medication on your own. Have your doctor or pharmacist help you adjust. Never start or stop a blood pressure pill, heart medication, or diabetes drug without talking to your doctor first. Step 5. Make targeted lifestyle changes that support both your sleep and your cardiovascular health, not just your bladder. Limit large volumes of fluid in the 3 hours before bed, especially caffeine and alcohol. But don't dehydrate yourself all day. Aim for steady fluid intake earlier. If your legs swell, ask if you can elevate them for 30-60 minutes in the late afternoon or early evening to shift some fluid back before bedtime. In some heart failure patients, light compression stockings may be recommended, but only with a doctor's input. Work on gentle, consistent daytime movement, walking or chair exercises, which can improve circulation, fluid handling, and sleep quality. Use a wind-down routine. Dim lights, turn off news and stimulating screens 30-60 minutes before bed, and if you are lying awake, use proven techniques like slow breathing instead of immediately leaving the bed and turning on every light. Step 6. If you are diagnosed with sleep apnea, take the treatment seriously. CPAP or other devices are not just for snoring. They reduce blood pressure surges, protect your heart rhythm, improve oxygen, and very often cut nighttime urination. Many of my patients are surprised to find that once their apnea is treated, their 3 a.m. bladder disappears or improves significantly. Step 7. Reassess. After 2-3 months of addressing underlying issues, blood pressure, blood sugar, heart failure, apnea, and making modest behavior changes, look at your diary again. Are you still waking at 3 a.m. like clockwork? Has the number of trips dropped from 3 to 1? Are you falling back asleep faster? Those changes matter. You may be asking, what if my doctor just shrugs and says, this is normal for your age? Be respectful but firm. Say, I understand that nighttime urination is common in seniors, but I've learned it can also be a marker of sleep apnea and heart problems. With my symptoms and list them, I'd like a more thorough evaluation. If you still feel dismissed, consider a second opinion, ideally with someone comfortable in sleep medicine or cardiology. Let me tell you about a different patient, Thomas, whose story went differently. Thomas was 78, retired electrician, with high blood pressure, type 2 diabetes, and mild kidney disease. He was 5'9", 188 pounds. His biggest complaint when he saw me wasn't actually his chest or blood pressure. It was, Doc, I'm up 2 to 3 times a night to pee and I'm exhausted. I think it's my prostate. He'd already seen a urologist, had his PSA checked, and tried a medication to relax the prostate. It helped a little with flow, but not with the pattern. Bed at 10, wake at 1:30, then again at 3:30 or 4. He snored so loudly his wife slept in the guest room. As I asked more questions, he admitted to waking with a dry mouth, morning headaches, and feeling like he needed a nap by 10 a.m. His blood pressure log showed higher readings first thing in the morning. His wife said sometimes he's quiet for a bit at night and then makes this choking sound. We ordered a home sleep study. It showed severe obstructive sleep apnea. He was having more than 30 breathing interruptions per hour, with oxygen drops into the low 80s. His heart rhythm monitor showed some runs of atrial fibrillation at night. We started CPAP. We also tweaked his blood pressure meds to better control his nighttime levels and moved his diuretic to the morning. We advised him to limit caffeine after noon, alcohol in the evening, and to elevate his legs for a bit before bed. For the first week, he hated the CPAP mask. The second week, he hated it a little less. By week 3, something clicked. At his 1-month follow-up, he said, "I still don't love the thing, but for the past week, I've only gotten up once at night, around 4 a.m., instead of 3 times. And last night, I slept from 10:30 to 5:30 straight. I can't remember the last time that happened." His wife chimed in, "And he's not snoring the house down." 3 months later, his blood pressure was smoother, his morning readings lower. His A1C had nudged down from 7.6 to 7.1, thanks to better sleep and more energy to walk. He still had a prostate issue, but the dominant driver of his 3 a.m. awakenings had been his apnea and nighttime heart stress. Once we treated that, his bladder problem shrank into something manageable. I think about Margaret every time a senior tells me, "I'm up at 3 a.m, silly bladder." I picture her shuffling to the bathroom, blaming her age, while her heart and brain were taking nightly hits from oxygen drops, blood pressure surges, and fluid shifts, all signaling through the only symptom anyone was paying attention to, nighttime urination. You now understand that waking at 3 a.m. to pee is not just a nuisance, it can be a red flag. You know that in many seniors, the bladder is not the main problem, but the messenger, pointing towards sleep apnea, heart failure, blood pressure spikes, diabetes, or kidney issues. You understand that hormones like ADH and atrial natriuretic peptide, fluid in your legs, and your nervous system all play a role, and that a normal healthy pattern is to make less urine at night, not more. You've learned that treating underlying conditions, especially sleep apnea and heart failure, often reduces nighttime urination far more effectively than simply cutting water or adding a bladder pill. And you have a concrete plan. Keep a sleep bathroom diary, screen yourself for warning signs, talk to your doctor about tests, adjust medication timing safely, and make changes that protect your heart and brain, not just your bladder. This information is power, but only if you act. Tonight, instead of just stumbling to the bathroom and cursing your bladder, take a moment to notice how hard is your heart pounding. Are you breathless? What time is it? Write it down in your diary. Over the next week, collect that information, then bring it to your doctor and say, "I want to know what's really behind this 3 a.m. wake up. I want my heart and my brain checked, not just my bladder." Before you leave, do 3 things. Subscribe if you want more direct, no-nonsense guidance about protecting your sleep, your heart, and your independence after 60. Share this video with at least one friend or family member who always gets up at 3 a.m. to pee. You may be the one who pushes them to uncover a serious treatable problem. And comment with one of 3 phrases. Bladder only, if you truly have only minor bladder issues and sleep well otherwise, suspecting more if you think there may be apnea, heart, or blood pressure issues behind your night waking, or talking to my doctor if you're now planning to bring this up in detail at your next visit. Your 3 a.m. wake-ups are not something to ignore or joke about. They are your body talking to you. Listen and respond while you still have time to change the story. Disclaimer: the content in this video is for educational purposes only and is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician regarding your medical condition. Never change your medication dosage or start or stop a sleep or breathing treatment without consulting your doctor.